All right, we're going to get started. It's 6 o'clock, and we're going to start our local behavioral health board meeting off with public comment. And I see we have a few people on Zoom. We have a few people here that made the drive out here. Thank you. Any comments from those present? Jen?
All right. I'm Jen Boucher-Dancer, Executive Director for NAMI Yolo County. And I just wanted to provide comment and some feedback that we've been receiving from NAMI members regarding the pause in mental health court. We're definitely starting to hear from people who are very concerned and upset about that. People who their own family members have benefited from it. I'll just read one comment that I received from one of our members who said, mental health court has been the one resource that has made a difference in the lives of our family members. And losing it means more distress for families, unfair practices to individuals who are mentally ill and criminalized, and higher costs to the county and court systems. It's a huge loss. So I wanted to share that. I anticipate that as more people begin hearing about this, that we'll be hearing from more members who had found it in either their own experiences or hoping, just in terms of having it available to others, that it had been very valuable and it made really significant differences in the lives of their loved ones and also for the family members who are supporting that loved one. So thank you.
Thank you, Jen, and thank you for teeing up that issue because I did get one of those comments, and I think it may have been the one you just read. And I responded to that person, explaining a little bit about what was going on. And because of that, and because I know there is some consternation in our community, rightfully so, to your right is Preston Shaw, who is the supervising deputy DA who oversees all of the collaborative courts. And I asked him to come and speak about this very issue during the criminal justice report. So if you want to text everyone who might be interested to zoom in, they can hear it. And if not, then you can share what he says with your membership, because it's a really, really valid point and valid concern. So thank you. All right. Any other public comments from people that are, hey, Nikki, people that are here? No? Okay. What about anyone that is here by Zoom? Any public comments?
Hi, I have a public comment. My name is Jack Johnson. I'm an assistant deputy to Supervisor Villegas of District 1. Just wanted to introduce myself to the board. I'll be representing Supervisor Villegas to this board probably pretty often. Unfortunately, he had a prior commitment tonight. But just kind of wanted to get our BOS update in now, just because I'm not sure how long I'll be able to stick around. But our only update is that we are looking to fill our vacancy pretty soon. We're going to be holding interviews for our District 1 vacancy and hoping to have that filled ideally by next meeting, but if not, then the meeting after. So yeah, just that. And yeah, if you guys have any questions for me, feel free to shoot me a message or an email works too. Thanks.
So Jack, we're so glad to have you here on behalf of Supervisor Villegas. And we also really appreciate the supervisor's efforts to fill the vacant seats. So thank you very much, and please send that same message to him. Thank you very much. Anybody else? All right, hearing none, and we'll have more opportunities for public comment as we move through the agenda. So let's go to item 2, which is approval of the agenda. I'll entertain a motion to approve the agenda.
So moved.
Moved by Chris, second.
Second.
Second by Sue. All in favor, say aye.
Aye.
Opposed? Abstentions? Okay. Approval of the March 5th minutes. I'm hoping everyone had an opportunity to review those. Are there any comments on those minutes? Seeing none, motion to approve.
So moved.
Chris, second. Second by Sue. And all in favor, say aye.
Aye.
Opposed? Abstentions? Okay, it's unanimous. Member announcements. Any member announcements? Chris?
I attended Opioid Coalition meeting. And I sent a video link to Christina to send out to the board. It's an addiction overview by Dr. Corey Waller. It's old, but it's not that old. It's out of date as far as the treatment. And it kind of gives an overview of addiction and the medication-assisted treatment. It's about 20-25 minutes long. He's a good speaker. It's a video that we showed to the attorneys in the DA's office, public defender's office, at an MCLE training on medication-assisted treatment, I want to say about 4 years ago. There's also a SAMHSA pamphlet on the medications that are available in the community program that kind of has some information on overdoses that I think would be helpful for the board members to get a feeling for kind of what's out there. And so she's going to send that out. One of the things I did want to point out about overdoses is that in Corey Waller's presentation, he talked about how 2015 was an epidemic, and there's 50,000 overdose deaths that year. And just going to June 2023, 2024, there's 97,000 overdose deaths. And the year before that, there was 113 overdose deaths. And those 2 years, the deaths were 4 times the amount of soldiers that were killed in the Vietnam War, just to kind of put that in perspective. In Yolo County, during that time period, we had 30 overdoses in 22-23, 28 were from fentanyl, and the following year there was 26, and 22 involved fentanyl. And so this is a topic that's local also. The Opioid Coalition will probably be having a booth at the county fair trying to beef up awareness. Let's see. That's it for that. If you have any questions about the Opioid Coalition or want to get when the meetings are, Christina might have that information, or you can email me and I'll send it to you. But they're basically noon on the last Friday of the month. And there's a Zoom ability to participate and also in person.
All right, thank you, Chris. Any other member announcements?
I wanted to bring up, I guess like kind of getting the ball rolling in creation of an annual report, because I've been poking around the California Behavioral Health Board's council website, and I saw a bunch of examples of how Napa and San Francisco and some other counties have made an annual report in the last couple of years. I think it's a very doable goal for this board to kind of initiate that process and potentially create an ad hoc committee with the goal of working on that.
Yes, and you and I spoke about that, and thank you for putting this on our radar. It's something that we do need to do, and so I was going to cover that and appoint an ad hoc committee under item 11. So thank you.
And the other thing I wanted to bring up is there's the California Behavioral Health Board's Council training on Friday and Saturday. I'm already planning on going, already registered, in case people weren't aware of that. So I wanted to just kind of attend that and report back with kind of what they discuss. And the third thing is I got the chance about 2 weeks ago to sit in on the 40-hour CIT training in Ventura and kind of see, so I was able to take the whole thing as a student, they gave me a post ID, and I was able to see, I was able to kind of sit in with the deputies as they kind of went through that training. There's a lot of different presentations from mental health providers, from social workers, from law enforcement, who are experts in different areas. So I kind of got to see the, I guess, more internal perspective of what the full 40-hour CIT training looks like. So.
And you are a graduate, right?
Mm-hmm. Of that?
Yeah.
I think technically, but then since I'm not law enforcement, I'm not sure how much it actually counts. But I did sit through the whole.
Yeah, so congratulations. That's great. And then you mentioned the Kelby HBC meeting. So I'm on the advisory board of that group, and thank you so much for attending. And I think we send out the invites. I don't know if people notice them. You guys can attend and even have some of your expenses paid for. This one happens to be local, but if they aren't local, we can send people and they'll pay for your expenses. So something to think about. So thank you for bringing that up, Kimberly. Any other member announcements? Okay, chair report. We have 2 new board members. We're really excited to have you here. And let's start with Jennifer Mullen from District 4, Sheila Allen's district. That's my district. So welcome. Maybe you could introduce yourself, tell us why you're here, a little bit about yourself, and what you hope to gain or accomplish or contribute to this board.
Jennifer Mullen, I work in Davis. I'm an educator in Davis, but multiple roles as counselor mainly, and administrator, and site and district administrator, but 25 years of really advocating for youth, and also lived experience in that I've had family members with severe mental illness and who've struggled with homelessness and drug addiction. I've had to personally navigate lots of different systems to try to get resources and access to support, so I feel like I have a lot to offer in that way. I come from the Bay Area, so I know a lot about Alameda County mental health, but have lived in Yolo County for quite a while.
But you're working in Yolo?
Yeah, I work in Davis. Yeah, I live in Davis.
And you're not alone in terms of family members?
Yeah.
You're in good company?
I read the meeting minutes from the last.
Yeah. Well, welcome.
Thanks.
And Stephanie Carlstrom
Yes.
from District 5, Supervisor Barajas. And I really want to thank our supervisors, all of them, but especially Supervisors Allen, Barajas, and Villegas for really moving quickly to make these appointments. That doesn't always happen, and I know it's challenging for them because they have so many appointments and openings, and it seems like I don't know if they're prioritizing this board, but maybe they're doing the same for all the other boards, but we really appreciate them finding us good people. So Stephanie?
Yeah. Hi, everyone. My name is Stephanie Kopstrom. I currently am a principal at Pioneer High School in Woodland. I've been a principal for the past 10 years, and prior to that, I was a teacher, so I consider myself a child advocate. We do a lot at Pioneer with Tier 2 and wellness teams, so a lot of supports for our students. So I'm excited to see kind of what you're doing at this level.
Excellent. And the law changes with Proposition 1 changed the composition of this board, where they really wanted to put a focus on youth. So having youthful members and people involved with the youth. So that's really critical, obviously. So thank you guys for being here. My wife works in the school district, so she's a paraeducator at Birch. So thank you. Okay, let's move on to correspondence. None, okay. And so this.
Well, outside of the NAMI letter.
Yeah, that was something
later
we
on.
already talked about, Jack.
No, that's my public comment to the innovation plan.
Oh, this is your
Yes.
comment, okay, that comes later. Okay, all right, well, speaking of which, it's now time, and we're ahead of schedule, I love that, to talk about the innovation plan, so I'm gonna pass it on to our interim or acting?
Interim.
I never know what the difference is.
Yeah, interim mental health director. Yeah.
Tony, thank you.
Yeah.
In theory, if you're active, you don't have full authority. If you're interim, you do.
That's another me.
That's what they told me at the university when I got appointed interim
So
chair.
Tony has full authority,
Yes.
Well,
don't abuse it.
that's good to
Tony,
know.
don't abuse it.
Thank you all for making time for us to have the meeting off the regular schedule today. As I discussed at the last local behavioral board meeting, we had a pretty ambitious timeline in order to get this proposal in. And you should all have a very brief presentation as part of the packet that we can go through here real quick. So on this first slide here, it's talking about the 5 components of the Mental Health Service Act, which I believe that all of you are probably painfully familiar with by now, but just in order to review, this is the last year that we'll be in the Mental Health Services Act in fiscal year 25-26. And the different components of MHSA, oh, here we go, perfect, are community sports and community services and supports, prevention and early intervention, workforce education and training, capital facilities and technology, and innovation. So the innovations funds come to us right off the top. They're 5%. So we don't have with some of the other funds, for example, like capital facilities and technology, we can transfer money into that section out of like community supports and services up to a certain amount.
Tony, could you speak up just a little bit? I must be going deaf.
I will do my very best, but like this is my normal speaking volume.
I know it is.
I know. But I will
know it
make
is,
a
but you're
I will
all,
make a concentrated effort to
Okay.
project my voice across.
or we can ask for the mic.
No, that's okay.
Huh?
That's okay. That's all right. I will.
I was sitting next to him last time and I said,
I do tend to have like a bit of a lower talking voice, right? I'm not like, usually. Some people have like that voice that fills up the whole room, and my voice fills up this part of the room. You know,
Your inside voice.
yeah, it's I think that's what it is. I'm the oldest of 6 children, and so, yeah, I have an inside voice. But anyways, the innovations funds come to us 5% right off the top. And so we either, under the Mental Health Services Act, either we come up with an innovations project or we don't have a way to expend the funds. Like we can't move the money to a different part of the, like we can't move the money into CSS or an EI or anything like that, right? In addition to that, there's some certain strings that get attached to all of our funding. As we get money that comes in from MHSA every year, we're able to keep a fund balance in different areas. But as we get to certain points along the way, we're at risk of reversion, right? You've probably heard about this in the past when we've had situations where we were at risk of reverting funds if we didn't spend the monies. And as you know, MHSA is a volatile funding stream. It's a 1% tax on millionaires, right? It goes up and down. And there have been times it's like boom and bust in Yolo County, right? There have been times when we had all of this money and it all needed to be spent. And then we've had other times when we don't have that much money. Well, what it has transpired recently, as I came into my role as interim mental health director, is that we were looking at potentially reverting $473,000 if we did not have an approved innovations plan in place by June 30th of this year. So we only had a few weeks to really prepare and develop a plan. And putting a whole plan together takes time. And going through the process, and you can look later in the documents on the very last page, which sort of has the timeline spelled out. But there's a number of different steps that have to happen. We have to have a 30-day public comment period. We have to have this hearing. We have to have it approved by the Mental Health Services Oversight and Accountability Commission. It has to be approved by the Board of Supervisors. So there's all these different steps that have to happen. And so when we were planning, we're like, okay, what kind of a plan are we going to be able to put together in order not to revert the $473,000? And there is an approved plan that is in place already by CalMesa. It's the California Mental Health Services Authority. Some of you may remember that is where Carlene Jakowski has gone off to, and she was very clear on the way out, like, I don't want to be a part of this conversation, but we've been talking internally, right? We have been talking, we've been talking internally for a long time about potentially transitioning to a different electronic health record, and I can get into that in a minute. But the context I want to give for you is that we had a few weeks to pull together a plan. And the most strategic approach for us was to piggyback onto CalMesa's already approved plan. CalMesa has, well, before we get into that, just while we're still on this slide, this is the buckets under MHSA that we are working with. As we go into BHSA, there's no innovation, right? There's no innovation fund. So this is kind of money that is sort of one-time funding for all intents and purposes. If we do not approve this plan, we still have other options, right? So if we were not to approve this plan, the $473,000 is at risk of reversion. And with the state of the state, it's probably pretty likely that we would end up reverting that money. But then we would still have the rest of the money that we could potentially develop a different plan for. As long as we have a plan that's approved and in place, and we spend at least $1 by June 30th of 2026. The third potential option would be we approve no plan, we don't develop an innovation plan. When the Behavioral Health Service Act kicks in on July 1st of 2026, these innovation funds would then flow into one of these three buckets or be evenly divided between these three buckets. I'm not 100% sure what the methodology would be, but the new BHSA components are housing, full service partnership, and behavioral health services and supports. So these funds, if we don't come up with an innovations plan, we aren't necessarily going to lose them. They could go into other services, but it wouldn't be until July of 2026. Assuming the state doesn't change the rules on us before we get there, okay?
I didn't follow the part.
That's an
$1.
assumption.
Oh. Well, hold on a minute, that's not what I understood earlier. Oh, my apologies. I have a fact checker, so this is really. We need to have a plan in place before July of 2026, or else all the money is gonna revert. So
When you say all the money.
So so the money that we have available to us currently is $5.2 million, right? And
That's
so
the innovation, that's the innovation budget.
That's the innovations budget. So, I thank you, Jennifer, for catching that. If we don't approve this plan, we wouldn't lose all the money, but we would lose potentially $473,000 of it. But if we don't have an approved plan in place by July 1st of next year, we would lose all of the money. They would revert, yeah. So, my apologies. I misunderstood that from some conversations we had earlier in the week. Yeah.
I just want to know, is this 5% of what we are expected to get this year, or is it 5% that was based on some other allocation?
So it's 5% of the MHSA allocation that the county receives each year.
Okay, so we're talking prospectively now. Is that correct?
The $5.2 million does involve it involves a fund balance, and it involves what we're anticipating to receive in the next fiscal year, yes.
Okay, because I was trying to do the math here, and I'm like, this is 5%. We're in better shape than I.
No, we're
No, okay. So we're talking fund balance.
We are definitely not. Yeah, there is
All right,
a
thank you.
fund balance. There is a fund balance of which we are subject to revert $473,000 if we don't have a plan in place by July 1st of this year.
Okay,
Yeah.
got it.
All right. I apologize. I did not mean to make that too confusing.
Well, I mean, we either have $100 million budget or we don't.
We don't.
But it's two different pots, right? One is the innovation, and that we have a certain timeline on, and the other is the fund balance, right?
No, the innovation, so each of these
Yes.
particular components, like CSS, PEI, WET, CFTN, and innovations, we can have fund balances in each of them. And there's a current fund balance in innovations because we haven't approved an innovation plan in quite some time, right?
Oh, so the innovation balance, so so we have the current year, which is the 4 something, and
No,
then
the current, so I don't have the exact figure on what the revenue is for the current year, right? I just know that we have a fund balance, right? And that with the fund balance that we currently have and what we're anticipating to get in the next fiscal year, that's $5.2 million collectively.
all innovation.
All innovations.
Okay, that's, yeah.
Yeah.
But not 1 year's allocation.
No, it's roughly 3 years of innovation. It's roughly 3 years of.
Why just, and I know you guys have been drinking through fire hose, but
Sure.
I just want to ask, why have we not kind of allocated and spent that money?
That's a
And I could probably answer it, but.
Go right ahead. Please do. So there was a proposed innovations plan in the most recent MHSA update. MHSA plan update, but it was never submitted. So there was a proposed innovation plan that involved Crisis Now,
Mhm.
and it was never submitted for approval, right? So that there was never a actual, so in the update, it was like, hey, this is what we're proposing to do, but no plan was ever developed. It was never submitted for approval. It never went through any of these processes, right? And having some conversations with consultants, right? There is some question about whether or not that is a plan that would be approved or not, right? So it is a plan that could potentially be approved, right? But there's no guarantee that it could or could not be approved, right? So I cannot speak to why an innovations plan was not developed in the past. What I can tell you is when I came into the role, I was advised that we were subject to reverting $473,000 in a few weeks if we didn't come up with a plan. And this is something that is needed. And this was really the simplest plan that we could come up with. I mean, let's be honest. I mean, we're here to be transparent, right? You know, we didn't want to revert nearly $500,000,
Of course.
right? And so the initial concept was not to spend $5.2 million. We didn't even know we had $5.2 million when we first started this, right? You know, the numbers develop over time, right? So as we're pulling the plan together, we were really only looking to spend about $1 million initially, right? It was just not to revert the funds. And then as the true numbers started to materialize and working with our fiscal staff, and as we were going back and forth with Cal Mesa about what this might actually cost, it started to make more sense just to request to use all of it. So the $5.2 million would cover 3 years. So we covered the implementation of the new electronic health record, but it also captures some of our staff costs that are being dispersed in other parts of the plan. And it also captures some of the costs that we currently are, that we're currently expending regarding our existing electronic health record. So we're able to pull in some of those costs into the innovations plan, which would free up that money that is currently in CFT10 to go into CSS to be used for direct services. So it's about $700,000, right? So, you know, just to like make it clear, right? This was the most efficient plan for us to develop. And it's to meet the need that we have.
I'm sorry, but what are the implications of that for the eventual rollout of Crisis Now?
Yeah, and I, that was my same thought. I don't know if Sue.
No, I'm
Like, because what I'm thinking here, and again, I want to be clear that I'm not, like, we trust what.
Right, we're not being
I trust what you're
critical.
doing.
I'm not gonna take any of this.
Yeah, and I know
Right.
you
Yeah.
inherited it from, you know, and Carlene was awesome. But so like what I think the three of us are thinking, maybe others, is, God, we've been hearing for so long that we're in dire straits in funding for Crisis Now. And why haven't we been using these innovations funds for Crisis Now? And why are we using these funds now for this plan, which might be really good and probably needed, but why not Crisis Now?
I think what I've heard over, since I've been here in Crisis Now, I've heard about Crisis Now before I was on the board, is that the concept was so expensive as originally proposed that it couldn't be done. It sounds like HSA has been trying to figure out how to implement a version of Crisis Now that HSA county can afford. And I'm guessing that we haven't figured that out in time to use these innovation funds towards it.
So again, I can't speak to why decisions were made in the past, or the way they were made in the past. What I can tell you is that we did not have we would not have had enough time to develop a plan to incorporate Crisis Now, and not revert the $472,000. So that was one decision point, right? And again, when we were initially walking through this, right? The idea was not to use all of it. It was really only to use a portion.
$473,000, the part that was.
We're $1 million. We were
Okay,
we were actually gonna request $1 million. And we were gonna leave the remainder for Crisis Now implementation. As you have all probably heard, right? Like we've had other, the money that was sort of earmarked for Crisis Now in this budget, along with other funds that we had identified for Crisis Now, in it coming together, it wasn't penciling out, right? I don't know how else to say it, right? I mean, it was just not penciling out. And it was starting to become apparent that it wasn't going to pencil out, right? And so, you know, internally, we made a decision to propose to do this because we could see where the, and when I say Crisis Now, like, let's be clear, we're talking about the receiving center, right?
Yes.
You know, the other
Yes.
components of the Crisis Center were already in place, right?
Right.
But there was other funding that, for the receiving center that had been, like, for example, there was like a federal earmark that did not materialize. There was different funding that had been, sort of informally agreed that would be there to fund the project. I mean, it just was not penciling out in a way that we could do the project the way that it was originally set up to be. So that's why we proposed this. And I mean, I anticipated this coming here. And the reality is that this is a proposal. There are different options, right? And we're here to get your feedback, right? And so if you don't think that this is the best way to use the innovations funds, then we're here to hear it, right? And if you think that we should table this and just say, okay, we're going to potentially have the $472,000 reverted, but we'd like to use the other funding in a different way, then we're definitely here to hear that, right? But, you know, we were making the best decisions that we could make based on the information that we had at the time we were making the decision.
So if we don't decide something today, we're likely gonna lose the
That's right.
$473,000.
Given that
Well,
timeline.
I mean, I also don't want to lay this all at your feet either, right? Because it still needs to be approved by the MHSOAC and the Board of Supervisors as well, right? And I don't know to what degree it requires approval from the board of the local behavioral health board, but there's supposed to be a public hearing and we're supposed to get your feedback.
Okay, but theoretically, we could recommend to just use
You
$1
could.
million or the $2 million.
You-
What I'm not clear on is, have we given up on the receiving center, or is that?
I'm not saying that we're giving up on the receiving center, but I don't think that we have enough funding in order to implement it the way that it was envisioned.
So we're not treating it as something that's in planning right now, then? It's more like this would be a nice thing to have at some point if we ever have the money?
I think with the county's current fiscal,
Condition.
thank you. I was about to phone a friend. With the county's current fiscal condition, I do not believe that the crisis receiving center, the crisis 2.0 is likely to happen.
So no decision we make tonight would have any impact on whether we can do that?
I wouldn't say that, right? But I just don't think it's realistic, right? But I don't want to say that any decision you make wouldn't have an impact, right? You know, I think that there is definitely still a lot of interest in making that happen, right? And there's definitely a lot of, I mean, just to be perfectly honest with you, pressure from local stakeholders, and we promised this to the community for quite some time, right? And so,
Yeah.
you know, I can't just say, well, we don't have money and, you know, see you later, right? What I can tell you is that from, you know, my position and what I believe to be true is that the county doesn't have enough money to do it.
What's the cost?
The total cost?
I mean, what do we need for Crisis Now? I mean, because we have $5 million.
You have, well,
Right.
you potentially have about 470 or $4.75 million potentially, right? So
What I heard from Brian
Hang on,
at Health
I just
Council.
want to hear, like,
Okay.
answer my question.
I-
I want to hear, like, what, sorry, what, like, so what is, and I just don't remember what the projected.
let me, can I come back with the actual cost of what, because I don't have the figure for what the actual costs are, right? I will say this, and this is, you know, the views of the interim mental health director do not necessarily reflect Yolo County, okay, right? So like,
We'll that at the bottom of every state.
That's fine. We made this promise to the community a while back, right? In one of those periods where there was money just flowing in through MHSA. I mean, we were getting pressure on, why aren't you spending the money, right? Literally. I remember being in meetings and like, what is going on? Like, why didn't you fund this program that I feel very passionately about, right? We heard that you underspent the MHSA allocation. And so at that time, it was like, yeah, we can do this, we can do that, we can do all of this stuff, right? And it made sense at that time, and now we're in a completely different economic climate. And I don't know how else to say it other than that, just one sec, other than that even if we did have enough money to do it, I don't think I would still be advocating for it anyways.
Because
right?
of the long-term commitment.
Just because, okay, like here's what I'm worried about, to be completely transparent with you. I'm worried that we are going to stand up a project that is not sustainable, right? And that we are going to have enough money to potentially stand up something. If we pull together all of our money and dig around the couch cushions and do all this stuff, and then we're going to have something that we can stand up for 2 or 3 years, right? And then at the end of it, there's not enough money to keep it going. And then there will be another round of political pressure about why we are failing the community or whatever it is that we're doing. Now, I believe in it. Don't get me wrong. I think we need it as a community, and I want us to have it, right? But I also think that we have like some other really pressing priorities right now that supersede this. Now, this is my own personal opinion, right? And I'm not advocating an opinion on the basis of Health and Human Services Agency or the county, because not everyone agrees with that opinion, right? But I'm here telling you the truth, right? Is that I don't think that we've got some pretty significant financial challenges, and we need the money for core mental health, right? And I'm not really, and I know that sounds like I'm talking out of both sides of my mouth if I'm coming here and saying we need $5 million for an electronic health record too, right? And again, I'm telling you that this is also something that the agency needs, right? In terms of a lot of the other challenges that we have had historically with making our electronic health record work, giving the community the other things that they need, right? In terms of a transparency and some like accountability about what we're doing on a macro level and our ability to provide data like that you've asked for in the past, right? And this potentially is a solution to some of those things. This is potentially a solution that would allow us to be more efficient and to be more efficient in building Medi-Cal and generating revenue in that regards. And it's an opportunity for us to become a lot more organized as a system of care, right?
Your comment about being able to better bill Medi-Cal to get the federal dollars is probably the biggest thing for me, which is why this is important, because it's my understanding is that our contract providers for FSP are not properly billing Medi-Cal because the records aren't up to par. There may be other challenges in billing Medi-Cal, and thus the county is losing significant amounts of money due to the inability to properly bill Medi-Cal. Is that fairly?
That's.
And that this record program would help alleviate that problem so that the county would get the money that it's due if it could properly track it and bill it.
That's our belief, yes. Right now, I want to just pick up just one second. And I know I cut Sam off too. I also want to be clear. So here's the thing: is like I'm not here to sell this, right? I want to be clear that there's not universal agreement about that either, right? And there's a lot of internally there is a lot of discussion about whether or not, and it's called smart care, right? That's in the electronic health record, right? Whether or not it can actually meet the needs, or whether or not CalMesa can deliver on the promise that it's making, right? The counties, they're developing it still, right? And some of the counties that are implementing it are reporting that there's bugs in the software, and they're trying to work all that stuff out, right? Now, I personally believe believe that they will be able to deliver on their promise, right? And their promise is, hey, counties, we know the state is constantly throwing things at you to implement, right? And every time you have to implement something, there's some sort of reporting requirement that comes along with it. And it requires you to modify your electronic health record and do all this different stuff in order to meet all those requirements. And we'll just cook it all in, right? That's part of the promise, right? And so, you know, I just want to be clear, right? Because I want to have a clean conscience here, right? Is that, you know, what I'm proposing, I believe in. There are other people within the agency that believe in it. Not everyone agrees on this, right? Just like not everyone is going to agree that this is the best way to spend $5 million either, right? So I want to be transparent about all
But
of
it's $1
that.
million.
Huh?
It's not 5 million, it's $1 million?
It's 5 million.
Oh, it's 5 million.
Yeah, it's 5 million.
The whole proposals.
The whole proposal's 5 million.
Through the magic of.
I don't think
the
the software system is fine.
So I just want to be really transparent.
Please do. I respect that.
This is really disappointing, and it's not assigning blame. There's a lot of things going on, but I mean, I think part of it was way back when, a few years ago, overpromising in terms of how much it would cost
When it was coming
and how
out.
quickly we could do it.
Mhm.
And then we pivoted on that in terms of what we could do and when we could do it, which was disappointing because this is so important for our community. And now, and again, you're the messenger. I know that, and you're new to, I know that, so I realize that.
Let's not minimize my role.
Yeah.
I'm perfectly fine
Yeah,
with
okay.
owning it.
But I just feel like now, I mean, my feeling is we need to go for the crisis now. And if we want to spend the money that we're going to lose on this, which probably won't cover it. I mean, so maybe we can't even do it. But I mean, I just think it's a matter of prioritizing. We don't know if this system is going to work. We also don't know if we can sustain crisis now. If it's as good as we all think it can be, maybe if we build it, they will come, like we can get the money, but I know you're a little, you have some consternation about failure. I understand that, in terms of being able to sustain, it. We've had a number of programs since I've been on this board where we've stood it up and they failed for various reasons and we had to roll it back or cancel it. This one though is huge. It's like one of the biggest, most important things I think for this community in my view, and I think many would agree with that. So again, this is like.
I mean, and I anticipated that, right? And I respect it, right? And again, we make the best decisions on the information that we have at the time, and it's been shifting quite a bit over the past few weeks. I know Sam is just dying to say something.
I really appreciate what you're saying, Jonathan, and I wish that we could tomorrow open up a receiving center. I really do. One thing that I want to just kind of emphasize though is that when we talk about Crisis Now and what Crisis Now meant, it's an entire continuum of crisis care, right? It's modeled on the premise of a person to call, someone to come, and a place to go. Or a number to call, a person to come, and a place to go. I have to get that right. And we have the number to call. We have a new high-tech call center that's actually paired with 988. So we have a much more robust number to call than we did a year ago. We now have a person to come 24/7 throughout the entire county. Now, there are still bugs that we're rolling out and fixing and, and improving on that, but we have a mobile crisis response 24 hours a day, 7 days a week, 365 days a year. And we have a place to go. We don't have the receiving center, but we do have short-term crisis residential beds that were added a year ago for the purpose of somebody who needs a short-term stay. It's still not the whole thing, and I don't mean to at all minimize the importance of a receiving center, but I also don't want to lose the fact that we have developed most of the Crisis Now model. And so I just think that that's important to bear in mind.
So what do,
Yeah, I-
Sam, what do we miss, what piece are we missing? Can you educate me?
We're missing the receiving
The receiving
center.
Meaning,
We're missing having a place to drop somebody off for 23 hours, up to 23 hours and 59 minutes.
the chairs,
and
chairs.
chairs.
It's the place that we went on the tour that they had at Sutter, that Sue and I were able to see, that had the chairs where someone could go for 23 hours. They may upgrade to 5150, they may go back in the community, but there's a place for them to go. And I think the fiscal part of that's been challenging as to where it's
Right.
gonna go and how it's paid for.
In the economy of scale and getting a size that would right size our budget and the community need and.
I mean, I also think that the community has been promised this thing, like, for it to be here and for it to like look a certain way and for it to be this certain thing, right? And while I just don't think that's realistic because of our financial, even with the $4.7 million, even with this money, I don't know that it's realistic to build it out the way that it was. I think that there may be another way to do it, right? And so like you said, right? I mean, we've seen other facilities that are already doing this, right? That are nearby, right? That's their kind of the business, right? Like that's what they do, you know what I mean? And so, I mean, I think that there are some other potential options to make something like this work. It's just likely not going to be here right now in the way that we envisioned it.
There's a couple things, sorry.
Two questions. The first one has to do with, were the consultants that have been talking to you about this and about its potential viability, the consultants who are working with the electronic health record rollout?
No. So.
I'm
when I
just
say- when I say-
asking, fair question. And it doesn't mean I suspect or anything, I just, and the other thing is, you guys have got to get some kind of story straight, because at Health Council last week, Brian talked about Crisis Now as though the only problem really, I mean, yeah, money was a little problem, but it was really about where we were gonna situate these receiving chairs. And so there's a whole audience of people from Sutter, from, all of the providers in the county who are listening to this as part of Health Council, who have the impression that although the corner is a little longer, we are about to get to it.
There's a couple things I wanted to bring up. So I've been kind of listening, I'm just gonna go through my points. So, one, I understand that in the current financial climate, county has to make some really difficult decisions, so I recognize that. And I also understand like the sustainability concerns, so we don't want to put up a program that's going to run out of funding in a couple of years, so just have something and then take it away, right? So I completely understand kind of like where you guys are coming from and not wanting to kind of lose 400,000 that's going to expire. So I see where we're coming from with all this, right? But another thing I really want to emphasize is I've done some digging on my own about kind of impact of or the effects of crisis stabilization units on a community, and in the literature reviews that I've read about the impact of crisis stabilization units. So like not just a receiving center, but a psych ER that can take 5150s. The benefits are very, very clear, both for providers and for clients. So even if it's not a not right now thing, I think it's something that eventually the county should.
There's no, I mean, no
Yeah.
one's, but
100%.
no one disagrees with that. right?
Yeah, so it's as in, like, it might not happen in a year or 2 years, it might happen when I'm 65, but then eventually, I think it's something that the county should work towards, because the benefits are so clear, not just with one area, but with kind of a whole range. If you look at reviews of many studies on how the effects of this are. The other thing is, I guess, like, how can we as a board advocate for this in the long term? And I kind of pose that as a question, not just to you, but to all of us, like, how can we advocate this, not just in a 1 or 2 year level, but eventually we get to there. And something else I wanted to bring up is, are there any other kind of in-between solutions for now? So we're currently still sending a lot of people on holds to the EDs, right? Or to, like you said, the kind of like the short-term crisis residentials, right? My question is, how do we improve that existing system? So how do we improve conditions in the ER? And in kind of speaking to people that work in other counties, something that I've heard suggested is like having county staff in the ER to kind of supplement what's already there, or having collaboration with other, like with the existing hospitals about kind of like how we're going to structure that system. So for example, in Marin, their crisis stabilization unit is like the structure was built by the hospital, but it's staffed by county employees. So the hospital, from what I understand, the hospital took charge on kind of building the like actual receiving center, but then it's the psychiatrist, the social worker and the therapist that are staffing that crisis stabilization unit are provided by the county. So it's a collaboration between both, and I'm like, can we replicate something like that in the county so we reduce cost?
And does the hospital own the building too, or did
From
they
what I
just
understand,
first buy it?
from what I
Okay.
understand, they do, but then I don't,
Okay.
yeah, I don't have all the facts backing that up off the top of my head, but that, from what I understand, that's how they described it. And something else I wanted to point out was like current gaps in the system. So a little bit of this is just kind of like anecdotal, but in terms of 24/7 mobile crisis, we have crisis clinicians 9 to 5, we have people on call after hours. That's not true mobile crisis, that's not true 24/7 care if it's on call, or if it's ambulance services providing that care after hours. What else? And the other thing is there's still some gaps in how the county crisis and access line is interfacing with 988, and that's still kind of being worked out. I think especially the location thing, for those that don't know, if you dial 988, it routes based on area code, not on location. So then if you get a county with a population of college students from other counties, so if someone's from San Diego and dialing 988, you're gonna get a San Diego call center and not here. So there's still some gaps in terms of that. So that's just a bunch of points I wanted to bring up, what I wanted to highlight, but yeah, I guess what I really want to emphasize is like, hey, how do we advocate for long-term for a crisis stabilization unit? And how do we improve conditions now? What are some functional ways we can improve like where people are going right now?
Okay, well, Nikki?
I'm just gonna say, because what I had been sitting here thinking was, Sutter Davis is building like mad. Maybe there's some space we could rent from them. I mean, maybe there's something that we wouldn't own, but we would staff and we could make it work for a longer period of time than if we were actually starting ground up on something.
Is the space the problem?
So I don't know if it's I'm not sure that it's it's something that I would limit to sort of like the infrastructure cost, right? Like, you know, the space.
Okay.
I mean, there's operating costs as well, right? I mean, I think it's just the total price tag of all of it in the current economy that is challenging, right? So again, I can't, so first of all, to your point, Nikki, I really can't comment on what happened at Health Council, but I'd be happy to follow up with Brian.
No, I just think you all ought to be on the
Yeah.
same page,
Yeah.
that's all I'm saying.
And then, you know, to your point, Kimberly, yeah, right, I think that's the best way I can to respond, like, you're right about all of it, right? I'm like, does this community need a crisis receiving center, and could this community benefit from a crisis receiving center? Absolutely. Like, should we have one? Yes. Like, you know, do we need to improve coordination between 988? Yeah. Do we need a more enhanced mobile crisis response system? There's no doubt about it, right? You know, and like, what can we do to improve things now? I mean, I think that's like something we're always working towards, right? And you know, I'm not trying to be minimize my role and say like I'm just here being the bearer of bad news, right? Like, I'm also a decision maker, right? That's putting forth a proposal that is based on a very difficult set of circumstances, right? And which I knew would not be popular, right? And, you know, I think that I respect your positions and your role in this as providing feedback about whether or not this is something we should move forward on, or whether or not it is something that we should say, no, making this crisis receiving center is actually more important to the community, right? And I respect that, right? And again, I'm telling you that I agree that we need that. And I'm telling you that, like, from my position and the way that I'm approaching this from a decision-making model, based on all the information that I have available to me and looking into the future, is that this is one of the options that I think is in the county's best interest right now, right? And again, if it's not the way we go, then it's not the way we go.
So you just said one of the options.
Mhm.
I mean,
the option is we could say no to it, and we could.
so there are other
We
good
could-
options.
We could scrap this proposal, and we could work over the next few months with putting together a proposal for Crisis Now and seeing if there's a way to pull it together, right? I mean, I think that the other funding that is connected to it is still very fragile as well.
And the only downside of that is we're gonna probably lose the 473,000.
We would definitely.
So we have Meg on the line. Meg is a board member. This is for Stephanie and Jennifer's edification. So I know you guys have or will watch the Brown Act presentation. You maybe know it already in your roles with the district, but the laws changed post with COVID. She's sick, and so I've accepted her ability to participate as a board member. I think there are only a certain amount of times a year you can use that reason, and another one is out on a business trip. So Meg, so normally if anyone could watch, if you can't make it, anyone can watch. If you decide like you're exhausted and you can't come, you can watch from Zoom, but you can't participate other than as a public member. So Meg is going to participate as a board member, and she has a comment.
Thanks, Jonathan. I just have a question. It's around similar. I was reading the notes, Tony, and I'm not sure if I understand it. The grant proposal around the mobile crisis for school. I'm just curious if you all thought about maybe if innovation funds could be used towards that, since we've already worked on that, right? We've already had some sort of model because we proposed a grant, and now we're pivoting a little bit on how we're going to support that work. But if I understand your report correctly, we're still have a significant gap with school-age children in a crisis model, having a dedicated crisis team for school-age kids. So that's, I'm just curious, if I'm not interpreting it correctly, just tell me you're not, and you'll explain it during the report. That's completely fine.
Yeah, I appreciate that, Meg. I want to make sure that I'm understanding the question. Are you asking us whether or not we had considered submitting an innovations plan to provide mobile crisis response for school-age children?
Well, again, the way I'm interpreting the report is we're not going to hire, you're pivoting resources with respect to that, so we aren't getting a true dedicated school-age crisis. And if that's the case, then my question is, since we already had a plan, could we use the innovation funds to fund that plan? Because it would seem to meet some of the qualifications. That was my question.
Yeah, and I mean, I can, I don't know where we want to go with the conversation, but just with what is in the mental health director's report with regards to the school-based mobile crisis, what we were communicating was that our initial intent was to hire a full-time clinician in order to fulfill that role, and we're not able to do that because of the county's hiring freeze, right? And so we still have the grant funding, right? But we're going to utilize the grant funding to support some existing positions and have some of those positions like pivot to providing that service, right? And the dilemma really is just that we're not able to create a position to hire for that.
So wait, even if we have all the money, we just can't, because I mean, the university has a hiring freeze too, but
That's
you
correct.
can apply to to hire necessary positions.
Yeah, my understanding is, and I've heard so many different things about this from all ends of things, is that, with non-general funds, like grant funds, that the board would make exceptions. And I mean, I feel like that's something that we could help advocate with to the board, because it makes no sense that they would freeze positions that aren't general fund and that are part of a grant. That makes no sense. And my understanding is, in talking to Carlene and some other, and maybe you, Tony, that they would be willing to consider making exceptions to that. If they said, no, it's black and white, we will make no exceptions, it's hiring freeze across the board, even if it's, grant funds?
Yes, right, so I mean, historically, that has not been an issue, right? Historically, if we were able to, identify funding that didn't have a general fund impact, there wasn't really a challenge. For a situation like this, we'd be able to fill a position with a limited term position, right? But in our current, and again, I don't want to speak out of turn, right? But currently, we're not getting approval to create positions, right? Even if we have all the funding identified, like in this position as a grant fund, we don't have authority to create the position.
I think that was my question. I mean, I don't know, I'm, getting caught up, right, my first night, but that's my question about Crisis Now also is, would you then have to hire people for Crisis Now? And then there's a hiring freeze, so that would be a moot point anyway.
I mean, there's yes and no. I mean, the intent was to do a request for proposal, right? To contract those services out. So,
Okay.
I mean, we would still have staffing costs that are associated with it, right? There's like overhead expenses and there's other things with managing the program, and you have to have individuals who are responsible with but yeah, I think without like trying to be too cryptic, right? And I'm willing to be as transparent as I can about the things I can be transparent about. And I'm trying not to be guarded around this, but like, I think what I want to communicate in one way, shape, or form is that the county's fiscal situation, and I think you guys remember Nolan Sullivan sitting in here before he was leaving, telling you like, it does not look good.
Right.
And we're here, right? Like we are here. And where I am literally telling you that even if I had the money, I would still be saying that I don't think we should do it. Because we have needs for other things.
Oh, okay,
Right,
but the
yeah.
idea is that you should be shifting the money to something else. Okay.
More pressing needs?
With like core mental health services.
Okay.
Like we have a structural deficit in mental health. Like,
But you can't use the innovation funds for core mental health services.
it has to be something innovative.
Right,
So you can't.
so that
Right,
money
that's
you
part
can
of the challenge with this funding source. And I mean, I knew that I anticipated this would be the response. It's $5 million. Like what, and again, I think it's arguable. Would Crisis Now be innovated? Maybe not. Like there's that, no one knows, right? Like it would depend on whether or not the MHSOAC would approve it,
And we do know that the MHSOAC did approve this plan, this innovation plan
Right.
initially, and with subsequent counties jumping on board and piggybacking off of it. So there's, from our perspective, a better likelihood that they're going to approve this innovation plan.
The difficulty I'm having is that if we don't even have sort of a rough number of how much the receiving center would cost.
I can come back to you with that. I mean, what I'm telling you is we've done a lot of the homework, right, internally, and it was not going to pencil out, right?
Okay, it's just, I mean, I don't want to sit here quibbling over a relatively small amount of money. If you were going to tell us, well, no, it's this huge amount of money, it doesn't really matter if you're sort of chewing around the edges here. So that's why it's hard not to at least have some kind of ballpark figure for it.
Mhm.
Okay. When you say you come back, you'll come back, do you mean like next month or?
I mean, I'll email Jonathan tonight.
Yeah, but
Okay, but we need
have to know tonight.
I mean, like, I don't have that figure off the top of my head, right? That's what I'm trying to tell you, right?
Is
No, I
it really
get that.
big?
It's a pretty big number.
I mean, it just makes it hard for us
Yeah,
to.
I understand.
Yeah.
Yeah, I understand. I mean, literally, I wasn't, when I came here tonight, I was really to talk about this, and not this versus crisis now, right? And the only reason I'm like talking about crisis now is because of the fact that it was previously identified in an MHSA plan as a potential innovations, as an innovations project, but it was never submitted. Right?
Can I mean, I'd love to hear the rest too of the presentation, but I had two questions. Tony, one was in the current electronic health records, your narrative describes a lot of making it easier for the personnel involved. I'm wondering if you could give an example of what exists with the new health records versus the one that you're currently using.
So basically you're asking what would be the difference?
Like what's an actual like illustrative example of like what the new health record could offer to the employees that makes their lives easier versus what they're currently utilizing?
Well, I'm gonna be honest with you, this is not my area of expertise, right? But I believe that there's like whatever the user interface in terms of like, like, for example, I was covering for Mobile Crisis recently, and so then I'm like actually putting in notes, and so I'm like trying to figure out, okay, like which episode is this, and which service code do I use, and what, and there, that's like a little bit more streamlined and efficient in terms of like kind of navigating like the particular menus and the way that things are laid out in order for them to enter the services in. Right?
Okay, so more like user friendly.
Yeah, go ahead.
I can provide a really concrete example too, is that, let's say a clinician conducts an assessment, and so they write up the clinical assessment, and it can be written up in a clinical assessment form, but then it needs to also be put in a particular form that will generate a claim.
Right.
But in order to generate the claim, the record had to have been opened correctly, and so the clinical diagnosis that was written into the clinical assessment has to then be entered into a completely different section of the electronic health record. And if it's not entered correctly, then there's a billing error, and so it gets denied. And so something like that repeatedly actually causes a fair amount of delay.
Are there any public, go ahead, I'm sorry.
So we're on the second slide. I don't know if we want to go through the rest of it. I mean, I think I've pretty much given you guys the meat of it, right? I think that let's skip the third slide here. I mean, the price tag's at the bottom of that page, right? On the fourth slide here, this is CalMesa's, I'm sorry, this slide here. It talks about what is it, right? And, to your point, Jennifer, it organizes the client health journey in a meaningful way that facilitates coordination and celebrates recovery.
And the plan also says that it reduces documentation time by either
Right.
30 or 40%.
Right,
Yeah.
right. And then the next slide here is really the illustration of what makes this innovative, right? And I will say that the one piece about this particular project, whether we do this, don't do this, or whatever, and regardless of all the controversy that there may be around it, it's pretty impressive in the way that they're able to organize data and provide information to the counties that are participating about how they're performing in certain areas. And so my closest equivalent to this, and it's something that I've been advocating for a long time, is in child welfare. The 58 counties have one case management system. It's the Child Welfare Services Case Management System, CWS CMS. And there are outcome measures that are established, right, for all the child welfare agencies. And that's through federal and state legislation. And so, for example, it's like, what percentage of children that are removed from their homes are reunified with their parents within a year or something like that. And the child welfare agencies are supposed to like meet certain benchmarks, right? There's outcome objectives, right? And they're able to, this is the idea, is they'll be able to do this, right? And they'll actually be able to aggregate data between the counties, because all the counties will have the same electronic health record. And it's really meaningful data that they're able to provide to the counties that are participating in. And we've been able to, like, we were fortunate enough to really go to like a 1-day kind of seminar type of thing. It wasn't put on to promote their electronic health record. It was really more about advising the mental health plans around some of their responsibilities as managed care plans. And it was with counties and the California Behavioral Health Directors Association. But it's really, there's a lot of power in the data analytics part of this project that would really be useful to us.
And would Cal Mesa be then providing that data to counties?
Yes.
Okay.
Yeah, and I think that it would be, for us, I think that there would be like dashboards or like ways
Right.
for us to view the data, right? But they'd be helping to put it together for us.
So if we have something like this, it might actually make it easier to make the case for something like receiving center, because we would have that data to make.
That is one of the
Yeah.
biggest challenges we have had since I've been here for the past 5 years, is getting reliable, accurate, meaningful data when people are asking for things, right? And I know, Sue has asked some questions in the past, and like,
Yeah, I mean, I was thinking the very first time I communicated with you, I was bugging you for numbers. So
that's
yeah.
right, and it's so, and I think that this would help a lot in that way. We can skip the next slide. Why now? Because. So I think that in terms of like some decision making, this is what I want you to know. One way, regardless of which way or another you would like to go, this would be the path for us to move this project forward, right? This is the public hearing, and there is a Board of Supervisors meeting on April 29th. And in order for this plan to be implemented, it would have to clear both hurdles, right? So it would have to be approved by the Board of Supervisors, and then it would have to be approved by the Commission for Behavioral Health, right? And so my understanding of it, at least, is that we're here to receive your feedback, and I don't think you guys have to tell us tonight, right, what you think, right? If you want to do it a different way, Jonathan, right? But I think that we can incorporate that feedback into modifying the plan or scrapping it or whatever, right? But the board meeting is really where a critical formal decision would be made, right? And so I think what I would say to you is that if you were opposed to it, right, and we still felt compelled to move it forward, that the board meeting would be the vehicle, right, to say that the local behavioral health board is adamantly opposed to this or something like that.
Yeah.
So the Behavioral Health Commission is different than the OAC, right?
No, I think in this case that it's referring to the OAC.
Okay, I was just.
I saw that look on your face.
Yeah.
No, the Oversight and Accountability Commission.
Okay.
So that they've done some rebranding.
They have.
Yeah, so it's like, they also call themselves the Commission for Behavioral Health if you go on their website.
Okay.
Because they don't
I
do
don't.
oversight and accountability. That's for sure.
Let's get some public comments if there are any. Anyone here in the room want to make a public comment? Jen?
Sure, Jen Boucher Dancer, Yolo County. I did submit written public comment, but this discussion has been very useful. One thing that I can say is that I have heard from frontline county staff for years, long before I ever came on board with NAMI, about the challenges with the current electronic health record system and how it was taking time away from them being able to serve clients. Those stories that I have heard predate the last 3 years with NAMI. And so we do believe that this is a valuable way to spend these innovation dollars. The point of caution, I guess, that we have at NAMI is as a community-based organization that does not provide services that are eligible to be billed to Medi-Cal, there's a little bit of worry that eventually we will lose our funding because we will not have, we won't be able to use these same types of integrated systems. So county staff has always been very supportive of the peer and family-led programs that we offer at NAMI. So I don't say this in that I'm worried right today that's going to be a consequence of this, but I do think it's important that we are not the only community-based organization that receives funds through VHSA that does not bill Medi-Cal. And so I want to kind of speak for those of us who would not be a part of that, for the county to continue considering those types of organizations and the types of services that we provide.
All right, anyone else? Anyone?
I had a comment, but
Let me finish.
Sure,
You can-
no problem.
We'll get you.
I was waiting till the very end and I,
Yeah. Oh,
With my
sorry.
own
No,
foot in
We'll
my
come
mouth.
back to you. We'll come back to all of us if people have comments. Any other public comments? From Christy.
Hi, everyone. My name is Christy Correa, and those of you that may not know me, I am a former Yolo County Local Mental Health Board member. I am a former Yolo County resident, and I am a parent of a loved one who was incarcerated in Yolo County during a mental health crisis and successfully participated in the mental health court diversion program. So my public comment, I just want to remind all of the wonderful people that are invested in this topic in the room tonight that the cost to the county as a whole, to not provide receiving chairs or a crisis stabilization unit results in either visits to the ER, no treatment at all, or incarceration. So that has been my experience over the last 3 years, studying and immersing myself in the Yolo County continuum of care and participating in Board of Supervisors meetings and calling for a stabilization unit in the county where we can take our loved ones when they need it. So the whole point of like Crisis Now and the continuum of care and the wonderful pieces that are in place already are to go upstream. So if we don't find a way to do something with the money that we have to go upstream, we are going to perpetuate the cost to the county, the sheriff's department, the probation department, the DA's office, the public defender's office, and we're going to keep people in jail and keep filling mental health court participant slots and keep putting the burden of this exorbitant amount on the criminal justice system. When if we can go upstream and find a way to find the solution, we can actually save the money county long term. So I just want to remind the room, of the bigger picture and the loved ones that are out there suffering or in jail that need treatment. And so these crisis stabilization units, can look like a lot of things. So I'm just urging this board to please dig in, create a committee, and find a way to provide our loved ones with chairs, with access to care 24/7. So we don't have to rely on the police or crowded emergency rooms to get medical treatment. Thank you.
Thank you. Anybody else? Public comment? Okay, Dee?
yes, so it's always hard to go after Christy. She has a passionate and productive angle to provide. So specific to the plan, if this is the proposed plan that the rest of my colleagues deem suitable to move forward, what was missing for me and something that I would need in order to further substantiate and promote this for the Board of Supervisors is the way I read this, it's written from a lens as though in a perfect world, nothing would go wrong.
Mm-hmm.
And for me, I typically like to know my risks up front before I go supporting a 3-year fiscal year investment of over, $5 million.
Mm-hmm.
So if we do have the time and this is the direction we choose to go, I'd like to see a SWOT analysis done that not only incorporates what Jen's bringing up, In a past life, I ran the statewide Medicare billing unit for the Department of State Hospitals, where we were dealing with a very antiquated legacy system and looking to transition to EHR system. It didn't happen in the 5 years that I was there. And so I'm sure that the modernization towards evolving to a more high-tech, modern IT infrastructure for medical billing is forward-thinking, and maybe we're in a lot better of a posture today in incorporating that, since we already have a similar model. Than Jennifer asked the question of kind of where I was going. And so I think that if this is something that we deem as a risk worth taking, because we can see the potential success and cross the finish line over the course of the next 3 years, I'm bought in. I do hear from the experts in the room, which I'm not one when it comes to the courts and mental health experience per se, but just from an outsider looking in perspective, anytime we're investing high yield dollars and I don't see what the potential risks are, that always gives me pause for questioning before I go on the dais or to a podium to defend our angle as a governing body.
Can I value add to your
Please.
time? And was there shopping around of EHRs, or was it just one specific?
We did not shop around. I mean, we're familiar with other electronic health records, and there's this specific one. Just in terms of, I could do a SWOT analysis kind of off the top of my head, but I think that if you want to get a high level understanding about some of the potential threats, right? And some of the risks, right? The behavioral health compliance officer, Catherine Barrett, is here with us, right?
Yeah.
And is someone who's pretty knowledgeable about the topic. And I don't know, Catherine, if you'd be willing to comment on some of the potential risks of this approach.
And before you do that, and I appreciate that, but I think we should remember just most recently, I think we all can recall that we were successful in getting the funding for our 2 public guardians, because what did we do? We pushed back respectfully and stated, absent having sufficient data that demonstrates and defends why we're looking to ask our board of supervisors to invest these dollars. Because I can go on the internet and write down and educate myself on the benefits so anyways, it's just another vehicle to influence in the decision-making process, and that's always going to be my angle.
I 100% respect that, and I really believe in making an informed choice, right? And that's why I'm trying my best to be transparent around like the areas where this is what I believe is why it's a good reason. And then like on the other hand, there's other things to consider, right? And again, internally, yes, there's some benefits that around the data infrastructure. Hopefully that the Medi-Cal billing would be more efficient, right? That it would be more effective and time efficient for our staff, right? But there are definitely some risks, right? I mean, it's new software. Some of the counties that we've interacted with have reported some challenges with it, right?
But I think that we're also leading into our board of supervisors with the understanding, assuming that they don't already know, Tony, so correct me if I'm wrong, but we're also leading into this discussion with, and by the way, historically, we didn't know that we had these hidden dollars that now we need to expediently expense.
So.
And we chose this as.
I don't know.
That would be a broach.
I don't know if I would frame it as that we didn't know that we had the money and, you know what I mean?
$5 million. I mean, if you're a layman's person off the street, you heard Nolan's presentation just a couple of months ago, and now we're saying we hit a windfall of 5 million and we need to hurry up and make a decision tonight to invest it or we lose it. And you're only given an hour to influence a governing body to say, yes, here's 5.3 million. I mean, that's a difficult argument for just somebody that fell out of the sky that had to listen to. Am I wrong?
So I get your point, right? What I would say is that, again, I certainly would not be framing it to my own board as that we didn't know we had this money.
Yeah, right.
What I will tell you, right? Okay. Is it me or you? What I will tell you is that when my team came to me saying, hey, we need a plan, right? It wasn't 5 million, right? It was
400.
it was like, no, that was, it was, I believe at the time it was 2.7, right? And again, it was, the urgency wasn't around the $2 million, it was around the $473,000 that was at risk of reversion, right? And then as we started developing the plan, the numbers started getting bigger and bigger, right? And so to that point, like when we were first working through some of the decision-making around what was going on with Crisis Now, the number was a different size too, right? And I don't know how else to tell you like that. I mean, you've worked in government, right? And so you get like, it's like, you're trying to get like an answer, right, around certain things. And I've been in budget conversations for the past couple of weeks, and there are a lot of different numbers that have been circulating. So to your point, I get what you're saying, right?
Yeah.
Like when Nolan was in here, we didn't know we had $5 million, right? I'll tell you that right now. We knew we had money, right? And the agency knew that it had innovations funds and a fund balance, right? But like to your point, right? The goal, I did not ever want to be in a position, right, to say, hey, we have this money and we need to spend it and we need you to make an answer right now, right? That's just the way it happened, you know? So I again, if you want to have more of a conversation about risk, we can definitely do that.
No, I'm just saying that whatever plan we do propose, it's better that we poke holes and make it bulletproof at this body.
Yeah.
Versus, I wouldn't come in support on the 29th and testify again with this as my binding document.
I appreciate that.
And with all due respect, whatever we learned this evening, absent you being there and testifying, the Board of Supervisors deserve a well-equipped report outlining all of the things. And we're already on their good list because we did that with the public guardian effort. So why not, no need to reinvent the wheel, let's just do that. And that was the only thing I noted in this is written from a lens that tells me we're not gonna have any issues. We're not gonna, incur any potential additional costs, right? Because we don't know. And so those are the things that I would be looking for if I signed on another one.
I get your point, right? Like whatever we bring to the board needs to be a little bit more informed.
Correct.
Understood.
Yeah, and I know that this was just for the presentation for tonight.
Yeah, no, understood. I appreciate that.
I have a call next week actually with a couple of counties regarding their experiences and some of the struggles they're having with Smart Care, so I can share it. Because it came up in a multi-county meeting regarding privacy and security. So I said, oh, I better pay attention.
Chris, you were gonna ask.
Is there an estimate as to if we do advance this new system, how much money may save or generate in correct billing?
I don't have an estimate on that, no.
And it's not something you're likely to be able to get. So.
I don't know if there's a way for me to estimate that, to be honest with you.
Can I ask a
Or
question?
maybe there is.
As you've developed the plan and you've noticed that it's gotten larger in expense, I'm wondering about the personnel costs related. So I can see the difference between the personnel and then the software system itself. Can you talk a little bit about the personnel costs in support of the change to the EHR?
Do you mean increased cost in personnel?
Yeah, in your budget narrative on page 12, there's personnel costs listed. And then I'm assuming the consultant cost on page 13 is the actual software system. So I'm wondering about the personnel costs related to the full plan.
I know that our intent with personnel costs was to pull in, so we currently have like system software specialists that we have that support the existing electronic health record, right? And so part of the strategy with using the innovations funds was to pull some of those costs that we're paying out of different funding sources and be able to use innovation funds to support some of those costs, right? And so I don't know that we're anticipating that we would have additional costs, right, related to the, like, the IT and personnel. But that this creates like an opportunity for us to shift some of those costs to a different funding source than we're currently using, right? And so then to free up some of that funding source for other things, right? And so, like, part of the reason that some of this cost is pulling up is a little bit, it's actually the plan is actually capturing more costs than just the software itself, right? So it's, part of it is the software and the implementation. Some of it is pulling some of our personnel costs from other areas into it. Some of it is actually pulling in costs of the existing electronic health record into it because there's going to be some overlap, right? And so kind of part of it is just like taking advantage of the fact that if we could get this approved, that we'd be able to pull some of those costs in other areas, right? And so, for example, one of the opportunities that we're hoping that we'll be able to present with this is that some of the costs that are being used to support the existing electronic health record in the amount of like $700,000 or so, that we'd be able to shift those funds, and because we're capturing them here, and put them back into direct services for clients, right? Because we can't use these funds for direct services for clients, and so it's like a roundabout way. Now, I mean, we're spending $5 million to get $700,000, right? But that's kind of some of the thought processes with capturing some of these staff costs, right? And so it's not like there would be newer or additional costs. It's like we're just capturing some of those costs in a different way.
I think that's an important part of the narrative if you are gonna say that then the money is gonna be spent on direct services, right? Yeah.
Okay. I appreciate that. Thank you.
All right, so, we have a number of options here. We can choose to do nothing here. We can choose to vote to support it, vote not to support the plan. And so what is the board's pleasure? I don't want a motion yet. I mean, someone could make a motion. Someone can make a motion, or if someone has comments on how they feel we should move here, what their personal opinion is. I have an opinion, but I'd like to hear from others.
I just don't feel like I have an adequate grounding to make a reasonable decision. And some of this has come from us beating around the bush for 6 years about the fund balances issue. I'm just not grounded enough to feel confident in voting one way or the other on it.
Mm-hmm.
But I would like to know, on the 25 counties that are in this consortium or this team that's putting together this plan, is there a representative group of counties with respect to county population? Are they all small or medium, some large, some small? Yeah.
They vary in sizes. So, for example, San Diego is one of the counties, right?
Okay.
And I'm just like off the top of my head, Sacramento. So those are larger counties.
Okay.
But I think San Joaquin, which is a county that's closer to our size, and I know that one of the really smaller counties was like, they have a waiting list of counties to join, right? And so, like, one of the very smaller counties, I forget, was it like Alpine or?
I think it's Tehama, maybe.
It was even smaller than that. It was a very small county. And so,
No.
I don't know, but it was a very small
Okay.
county, and there's a potential that we could kind of have their spot because they're so small that, like, it wouldn't really harm them to delay their implementation. So there's a pretty wide berth.
Okay,
of
that's
counties.
all I wanted to know.
Yeah.
And with respect to what Nikki said, and I think Tony made this clear, like, we're advisory, so if we decide not to do anything, if we decide to not support it, it does not mean that it's not going to be voted on by the board. So we're just.
Jonathan, Nikki, I had a question, or another way of looking at this was someone who's not as tenured and experienced being on this board, and something that came to mind is, given your comment you made, have we had an opportunity, when I say we, you, and anyone else that served at the same time, have we had an opportunity to have a proposal put in front of us where we agreed to adopt it and then tracked it throughout its life cycle, and then had an outcome that told us, you know what, sorry, Health and Human Services, we believed you this last go around. We tracked this proposal from start to finish, and unfortunately, we didn't achieve the desired outcomes as initially outlined and explained. And here's where we believe you dropped the ball in these respective areas. Do we have a case sample like that?
It's not as tight as that.
Okay, and here's another way to look at it based on your comment, because I appreciated it, is the way that I would see this as, I would be willing to make the motion with the understanding that I would need to see a little more substantive
We don't have time.
data to, well.
But I love this direction, right?
You would still have to have something
Well-
to provide the Board of Supervisors.
Well, I'm sorry for interrupting. We could do whatever we want. We could say, in principle, we like this, we wish we had more data. It can be whatever we want. It's just advisory. So it can be, like, we're a little reluctant, we wish we had more in light of the situation we're in. It seems like a good idea. We do need a better data tracking system, and we can do whatever we want.
Okay, because where I was going with my thought, and I live in a world of second chances. I work with the incarcerated population, so I would like to give this proposal a chance for this board to be able to say, okay, while we may not fully agree, and unfortunately the priority for all of us was the Crisis Now project, we don't want to completely be SOL with this funding available to us.
That's how you would phrase it to the board.
We're willing to adopt your proposed plan with the following, criteria or guardrails. And then because all of us still plan to be a part of this board and would essentially be measuring 3 years of a commitment that you made, despite some of us feeling that, we were made to believe, look at this hand, but not this hand, and we didn't have money, and now we do have money. But it's fair to say that, under current leadership and with the level of transparency and the partnership and the commitment that we're all making to see something through, because that's, in full disclosure, one of my frustrations is we need to act, and we need to act intentionally and with an understanding of, in our action, we also need to be committed to tracking, monitoring, and then measuring what a full productive outcome looks like. And I think this gives us an opportunity to do that. And I'll just leave that there based on the comment you made and what triggered this comment for this group. I am prepared to make a motion, but I want to hear everybody else's thoughts or comments in case that surfaces something that someone else feels compelled to speak to.
Other comments?
Well, I would feel comfortable making a motion right now if what we were saying was, we support this proposal as long as it's not at the expense of Crisis Now. That's where I am. I don't know.
I agree with that. And I haven't been hearing that personally. But then again, we're all a little gun shy.
Well, since we're just advising the board, the supervisors, though, what we're saying to them is, we'd rather have Crisis Now, but if we're not gonna get that, then we support this.
I agree. And I think that.
Or if we're not gonna get that right now.
Right, yeah.
Well,
Thank you.
well, and
Thank you.
I like that too. And one of my concerns, because I think we do need a good data system. It was really helpful working with the DA's office for all those years, having one of the best data systems in the state and being able to capture data and figure out how data can drive change and make us better. But I just and I'm just throwing out my feelings about this. We're to save $473,000, which is a lot. We're giving up the potential opportunity of $4.5 million that could go to Crisis Now, and that's gone. So we won't have that money for Crisis Now. So doing this.
I just want to put a caveat that there's
Yes.
no guarantee that we could get the money for Crisis.
No, I know. No, I get
All right,
that.
okay.
No, I totally get that,
Yeah,
but we're
just-
giving
I'm not-
up, and that's why I said the opportunity. I didn't say
No, understood,
we're giving up
understood.
$4.5 million that would fund Crisis Now.
Understood.
The opportunity, and that's hard. It's a hard pill for me to swallow. So, but what you said, I like the way you phrased that, because I do understand where you're coming from and the need.
Here's the thing, it's like, I fully respect everything that you guys are saying, right? And if it was really, if it was truly like, hey, we can either fund this or fund that, and I knew that we could fund a crisis receiving center that could be sustainable and be a permanent part of this community, I would never come to you with this. Right? I mean, it's absurd, right? So, you know, I get it, right? You know,
you're the first person who's actually told us that Crisis Now had never been presented as part of the innovation package. I'm telling you, it knocked me off my feet because it was absolutely news to me.
well, any innovations plan would have to come through here.
Well, we voted to support it in one of the 3-year plans.
So my understanding is that, my understanding of the history of this is that there was an innovation plan that was approved for some sort of learning collaborative around Crisis Now, right? You know, so, I mean, I think that there is reason to believe that Crisis Now could be approved, right? But like, there's no guarantee, right?
No.
Yeah.
And
Well, but it had been discussed like on
It-
a number of
it-
times, like it was
I-
gonna happen.
I understand that, yes.
Yeah. So, I mean, and I feel like I also work with incarcerated people, or my career was in a different way, you know? But I believe in second and third and fourth chances, in spite of the fact that, you know, my career was as a prosecutor. And
I
there
mean,
have been- and there have been,
third
but
and fourth, I get 3 and 4 chances.
Yeah, no, I
I
feel like you guys have had that many chances. And I'm not saying that because you're out of chances. I don't feel that at all. But there's been,
I
over
know
the
where I
last
could
5 or
be,
6 or 7 years, a lot of these
I know.
things that.
yeah, and leadership changes and direction changes, and I don't hold anybody in this room responsible for any of that.
Look, I mean, again, I'm like, I've been here 5 years. I've been part of the behavioral health system for 5 years. I mean, even though it's interim, like, I'm not trying to be, well, I just got here, right? I'm not trying to be that person, right? I mean, I'm here, I'm here to own it, right? Yeah, like, and, right? I think we've all been in a situation where we said, I want to do something. And at the time, we had every intention of doing it, right? And we thought when we had the resources to do it, and then situations change, right? And I just think that is where this agency is. At the time we made the promise, no one thought we couldn't, at that time, everyone thought that we were gonna deliver on it, right? I don't think that anyone doubted that we were gonna be able to deliver on that promise. And then there has just been one series of setbacks after another, right? And I ain't trying to make excuses, that's just the way it is,
Yeah,
right?
we appreciate that, Tony.
Yeah.
So, we're gonna end up going a little late today.
Sorry.
No, that's not your fault at all. I just hope I apologize, because I really try to get people out on time, but this one's gonna go a little later, because we're gonna have an important 10 or 15-minute presentation compressed in, and that's really important. So I apologize for that. I think we're ready for a motion. So, I mean, unless other people want to weigh in before we do that, I'll give anyone the opportunity. We're getting short on time, although this is really important, so I don't want to cut it short.
I just wanted to echo a lot of the things that all of you were saying, in that, you guys had to make some really difficult decisions, and then, like, we don't want to lose any of the innovation funding, but the thing is, like, I think, this board, and then historically, has been trying to promote, like, hey, like, let's have a receiving center, and to kind of see, like, that there hasn't been a lot of progress in that in the last couple of years is kind of, I just kind of wish the situation was different, but I guess from my perspective, it's like, how do we work towards having a crisis stabilization unit eventually? Because this is probably not going to be a year fight, 2-year fight, 3-year fight. It's going to be kind of like long-term. Because I want to be like solutions oriented and finding a way for that to happen. If it's not going to be with this, right? Like, how are we going to work towards that at a later point?
Okay, anything else?
I would just say that I think a lot of us have asked questions about data that you don't have answers to, that I would think that the Board of Supervisors would want that information, so that when you're putting the proposal before them, hopefully you have that information.
Appreciate that.
Yeah, I can make a motion. Well, my motion is what I already said, that, move to advise, the supervisors to adopt this plan with the understanding that this does not affect our ability to get the receiving center.
I'll second.
You're getting that down, effect.
It's not my, I don't know if it's my place to comment here, right? I just want to make sure there's clarity around what you're motioning to the, or I'm sorry, advising the board of. And if I'm hearing you correctly, it's, we only want to approve this if it means that the funding, even with this funding, that the crisis receiving center wouldn't happen, right?
I don't know if I would phrase it that way, because I'm not really
I just wanna
ready to
make
give
sure.
into it not happening. I'm just, yeah, this decision does
We
not
don't-
make any.
We don't want to support this at the expense of the
Exactly.
crisis.
Yes.
Understood. Because I heard you say that earlier.
Okay,
Okay.
go back to what I said the first
Sorry.
time.
Okay, we have a motion, we have a second, any discussion? All in favor, say aye.
Aye.
Opposed?
And it's, oh, sorry.
And Meg? Meg,
I'm thinking, yeah,
do you want, yeah, so we're voting, so I asked for the ayes, and you don't have to vote,
yeah,
not
no,
being on the spot,
I'm fine. Oh, I for approval.
okay. Opposed? Abstentions? All right, passes unanimously, thank you guys, we appreciate it. Okay, next we are, on,
Right to that door.
back to Tony for the mental health director's report. If we can keep this sort of short, I don't know.
I will do my very best to be succinct. Is there any particular items that you would like? to
Yeah, and I feel like I don't have the whole packet.
It's kind of weird. It looks like if you go to the second page, that's the first page of the report. And then you go later on into the document after the last board meeting notes. And it has this graphic on the.
Where's
second page.
A? Where's A?
A
It's
is
on the
on the
second
back
page.
of the first page.
The back of the first.
You printed it separately.
Oh, got it.
Yeah.
Got it, that's what I was, okay,
And
so.
then it picks up again right here.
Got it. Okay, so let's, if you could, if you guys wanna, again, let's try to be a little conservative about this, but again, I don't wanna stop you for something you wanna talk about.
G and I.
And, so Chris says G and I,
And Sue wants B, H, and
B, H and I, okay?
I don't know if I can be wrapped into the presentation.
Oh, is I the criminal justice report?
I have the court update.
No, yeah, so we don't need I. That's really.
Oh, we're doing it separately.
Yeah,
Okay,
and
then you
that's
can take
really-
off I then.
That's really a criminal justice update. I mean, I'm not sure why that's there, really. It's really a criminal justice update. Okay, so we don't need I. Anyone else? Anything other than B, H, and G, or B, G, and H? No. Okay, so B, Sue, what's your question?
I was just hoping we could get a little more information on the SAMHSA funds, if you have it, about what we're losing.
We're still trying to determine some of that right now, and I mean, I think that part's not 100% clear to us in the first place, right? And so the messaging that we're getting from the state really is that they're kind of putting us on notice, like, hey, we're not guaranteeing we'll pay you for anything that you do after March 24th, but we're also not saying that you won't get paid, right? We're not guaranteeing. So I can come back. I would actually like, at the next board meeting on the 7th, Jonathan, if it was okay, I would actually like to propose that I would come back with a little more detailed budget update in general. And I can include that information in that update, if that would be okay. We could talk about the specific programs that are affected. Okay.
Or if there's a lawsuit that might be impacting the outcome of this?
Yeah, we'll try to get an update, but I mean, I think that I would like to also have an opportunity to come back and give the board a more comprehensive update on the state of our budget.
Sure.
Okay, for now, are you just going forward as if you do have the funds, or what, how are you doing?
We're pausing on
Okay.
some of the things, and of course, some of the individual contractors are having to make their own decisions on the level of risk they're willing to take about not being refunded.
All right, G, Chris.
Do we have any numbers on the individuals that have gone into kids court? And if we don't, can we get them for next month?
I'll bring them next month.
Okay.
All right, H, Sue.
I was hoping we could just clarify, now that we're losing the mobile children's crisis response. What is the state of crisis response right now? If I call for help today, who's coming?
So if you call our hotline, well, I guess it really depends on what time of the day you call, right? If you call the hotline, we have internal staff who can respond. Also, we have the co-responders who are embedded with law enforcement, right? So if there's an individual out in the community who's having they'll respond to anything after hours, right? If you call our access and crisis line, then we have a relationship with AMR. And so AMR has individuals who respond, and we have clinicians who are available remotely who can come to the scene or participate in that.
Okay, so it's still true that we're no longer handcuffing children and putting them back in police cars. That is not.
Oh, well, depends on what's happening.
So I can't speak to whether or not we're handcuffing children and putting them back to the police.
Well, I
cars.
mean, what we used to do, it wasn't that long ago.
I don't know that is or is not happening, but I will tell you that the school-based response, the intent is for us to come and respond instead of law enforcement, right?
Okay.
And so the original plan was to have a dedicated clinician to it. We're not able to fill the position, so we're using our other co-responders to do it. And we're still building out that system of care. I can't say that what that is or is not happening right now,
Okay.
but the intent is to not have that happen. Like literally the whole point of this is for us to have clinicians responding to schools when there's a mental health crisis. And I think that we have enough resources around that between our mobile crisis project and the K-12 school partnership, which also has dedicated clinicians, that we should not have a situation where law enforcement is having to respond to a school unless there's some sort of a safety issue or something.
I can give you an example. Yesterday, we had a situation and the clinician wasn't available in Davis, so they send the clinician with the PD or the clinician first and then PD. And PD called the county, and the county sent someone out and did the clinical assessment.
Thank you.
PD was not involved at all.
Thank you.
But, and so again, to the point, could there still be situations where that's not handled the way that we want it to be? Yes, but we're trying, like the whole goal is to not have that happen.
Thank you.
So, and just getting back to our mental health director's report, the process is, you read it, and then rather than have Tony go through everything, we ask each of the board members if they want to pull items, and then those board members will say specifically what they're interested in. Okay.
So just coming back to item G.
So
We
we've
have,
had 7 petitions so far for CARE Act. We've had 7 petitions, we have 1 active case, and the other petitions have been dismissed.
Have there been any referrals from criminal court? I know there's a process for that.
We can find out. I don't believe that there have been.
Okay, that would be for individuals that are confident to stand trial in this
Right.
case.
And I can tell you statewide, so some of you might be thinking, those numbers are very low for how many months now?
We went live in December.
December, but I think that's pretty consistent statewide, that the numbers of referrals, for whatever reason, are very low and not as high as we had hoped or anticipated, I guess. I don't know if we hope.
Can I ask for clarification on who's the petitioner? Like, who can be the petitioner?
The petitioner can be family, it can be a behavioral health provider. The petitioner can be a wide range of people.
Okay, it doesn't have to be self-referred, which
Correct.
rarely happens.
It can be self-referred, but it doesn't, yeah.
Okay, gotcha.
All right, so we're on item 10.
Before we move, the next month, can we get an update on SB 43?
Yes,
Presentation.
yeah.
Okay, we're up to item, we already did that. I think we spoke at public.
Oh, that was, oh.
Yeah. Okay, item 10, as I mentioned earlier, we have Preston Shaw from the DA's office, a supervisor over there.
So, was item I brought up?
Item I was not brought up because we're doing it right now.
Okay.
Yeah, it really, I mean, that's not really technically your report to give, it's more the criminal justice
Okay.
report, collaborative courts. So
I can provide, I mean, are you gonna provide an update about what happened in CCP?
he's gonna do the report.
Got it.
Yeah. So we're set.
Okay.
Okay, take it away.
So, thank you everyone for inviting me. Again, Preston Schaub, I'm one of the supervising DAs. I inherited Chris Volpe's position once he retired. He looks great, by the way. A correlation there somewhere, I'll kind of figure it out. I've been meaning to come in, introduce myself, and get some face time with everybody. I really hoped it would be on a topic that was a little bit less controversial and a little happier to discuss, because first impressions are really hard to undo. But just to give you some context into kind of who I am. I am a Yolo County resident. I live in West Sacramento. My career path prior to becoming a prosecutor was in the psychological fields. I wanted to be a forensic psychologist. All my schooling prior to law school is involving psychology and forensics. It was a passion of mine, and I made a very late career switch based on an internship that I got. I also have family members who suffer from severe mental illness. I also have family members that suffer from substance use issues. I'm coming into the situation professionally, personally, philosophically. I'm trying to attack this from all angles. And so I just want to kind of provide some context for what's going on. I'll keep my portion pretty brief. I'm anticipating you're going to have questions for me, and I'm going to do my best to answer them as I can. But here's sort of the general gist. So with the passage of Prop 36, which we consider to be a mandate from the public, those who don't know the statistics of it, it passed with nearly 70% of the vote in the state, which is almost unheard of when it comes to propositions. If you're beating 50%, you're doing pretty good on a proposition. We were close to 70 on this one. Really demonstrates sort of the views of the community members and how they see substance use issues and the correlated issues around homelessness and mental health and all the sort of intersections of that world. They have not been satisfied with the way we've been handling them over the last decade. That became pretty apparent. So, common theme tonight, resources are finite. We have to make tough decisions. Thank you, Tony, for warming up the crowd. I appreciate you taking some of the heat early on. Much respected. So now we're forced to make some difficult decisions and have sort of a unique opportunity to kind of reevaluate the way we've been doing things with the criminal justice system and see if there's a way that we can sort of diversify the treatment to catch a larger population that we historically, I'll just say it, have been failing. And you see it in the community, you see it in the streets. Anyone who spends time in any of our downtown areas, you've experienced it, you know what it looks like. It's heartbreaking. And the collaborative courts have been a huge success in a lot of ways. And sort of the, as we say, the secret sauce behind that is just the sheer amount of resources and manpower that have to go into those programs. We have multiple probation officers, multiple clinicians, peer support workers, court staff, public defenders, conflict attorneys, prosecutors. The sheer amount of financial and human resource that gets poured into that program is huge. And the capacity for us to treat in, when I say the collaborative courts, I'm referring to our 3 collaborative courts, which are the mental health diversion court, our addiction intervention court, and our mental health court. The maximum amount of people who can serve in those programs is 90 at any one given time. The shortest amount of time that one of those individuals can successfully complete that program is 18 months. In reality, due to missteps and other issues that are common when we're addressing these issues, it's usually closer to 2.5, sometimes 3 years before we can get an individual through that program. So that is almost 3 years of time, money, and energy being spent on a very small portion of the population that needs a lot of help in our community. And on top of that, the requirements to get access into one of those 3 collaborative courts are very high. the level of insight that that individual needs in order to benefit from that treatment is huge. If they don't have that level of insight, they fail. And when they fail, they suffer pretty substantial criminal justice penalties sometimes because of that. As a result of that, we historically reject 2/3 of the people that apply for those programs because they just don't have the ability to engage in a way that's going to actually benefit them at the end of the day. So you have this new mandate from the public that they want us to treat substance use differently in the state. We create this mandated treatment approach to it. And for those who don't know, basically what it requires is if we file one of these felony drug possession charges, there's a theft version too, but I'm going to focus primarily on the substance use statute for this portion of it. If you're filed with one of those felony charges, you have an option. You can go through an assessment process. You can enter a guilty plea to the felony charge and go through a mandated treatment route. And once that treatment route is successful, then those charges will get dismissed at the end of the day, and there's an automatic process to have your record expunged as well. And the alternative, if you don't choose to take advantage of the mandated treatment, then you're routed back through sort of the traditional prosecution model, and your sentencing could be different depending on who you are. It could result in probation grants. It could result in local prison sentences. If you have a repeat of those felony charges and prior convictions, it could escalate to a state prison sentence. So there is sort of an escalation that happens here during this process. But the goal is we want people to avail themselves of that treatment path because we don't want to be sending people to prison for simple possession of drug offenses. That's not the goal here. Sometimes the unfortunate reality of our system and the way this works is in order to keep someone safe and in order to keep the public safe, sometimes we have to make that decision and send someone into a custodial setting where they're not able to gain access to drugs as easily as they would on the street. They certainly are still able to access controlled substances in prison. So it's not a perfect solution, but at least it provides them a place that's sheltered and they're able to gain access to resources if they so choose. So it's not a great solution, but in our view, it's better than leaving them out on the streets, suffering from the addiction, exposing themselves to potential fentanyl overdoses, lots of violence, lots of issues that come with that community. So in order to kind of gain access to that population that we historically have not been able to serve successfully, we have to start thinking about where we're spending this time and where we're spending this money. And so when it came time to set up a formal Prop 36 process in the county, we made the executive decision to pull out of our collaborative courts so that we could, the goal being, be flexible with their resources and be able to sort of navigate people into these different positions that they may need to go to based on their needs, prioritizing the Prop 36 treatment, because again, that is now the law. And we are, at the end of the day, obligated to make sure that we are following the law and having that process set up. So that is what we're focusing our attention on. Assuming that that process gets fleshed out, which we do have a working model right now that we have started to use. I'll just give you some quick statistics because everyone loves statistics. So far, we have filed, I believe, 60 of these felony drug offenses. Of those 60 felony drug offenses, we've had 11 people ask for the mandated treatment as opposed to going through the traditional punishment route. Of those 11 people, a majority of them fell off the radar once they said that they wanted to be using that treatment. So right now we only have about 3 or 4 people who are in a position to actually start engaging in that mandated treatment portion of it. It involves a referral to the probation department, who then refers the client to CommuniCare, and CommuniCare does a Prop 36 assessment. They create a formal treatment plan, and then assuming we're satisfied with that plan, the court's satisfied with that plan, and the defendant and their attorneys are satisfied with the plan, at that point the pleas are entered and that treatment process can begin. So that's sort of the formal way that it plays out in court. So at the end of the day, Unpopular decision, completely understand that. I don't love it personally. I understand that we're making a sacrifice. But here's sort of the double-edged sword of prosecutors, right? We are both a huge asset to the community and in certain times a huge problem because we are vested with so much discretion and power. And it all comes down to how we wield that discretion and power at the end of the day. We are the gatekeepers of the criminal justice system. I cannot stress this enough. We were never meant to solve this problem. My profession and the courts and the probation department, the DA's office, the public defenders, we were never supposed to be the ones to figure out how to get this treatment to the community and how to make it work. So we took a system that was inherently designed to do a completely different thing and tried to force it to work the way that we thought it needed to work in order to get treatment into these communities. And that involves police contacts, that involves periods of incarceration so that there can be stabilization and people becoming now for the first time in their adult lives, maybe meaningful access to psychiatric care and medications while in custody. We become the access point for it. You know, there are other access points obviously in the community, but because this population is plagued with these issues that will eventually devolve into law violating situations, we now have become the popular access point for people to get services in the community. And that is, again, one of the failures of the overall system, because now we have to make this thing comport with that mission, and we're experiencing tremendous growing pains because of that. So at the end of the day, the services that those populations should be going to the collaborative courts, they're not going anywhere. It's sort of the form in which it takes that is changing. There is nothing stopping me as a prosecutor or any of my colleagues from recognizing that there's an individual with a serious mental health issue and they need treatment over punishment. We have historically been able to craft those resolutions, get them access to those services without the existence of the collaborative court. We're going to keep doing that work. The formal process, and we're still playing it out. It's not like we had the people who were participating in those collaborative courts all of a sudden ripped out of them and just shutting down. Those individuals are still playing through the commitments that we've made to them to the very end. So we're still very much active in those collaborative courts. I still staff them. I still attend all the meetings and discuss how we're going to address issues with that population. We're just not adding to that population until the mandated drug treatment portion of it has some momentum behind it, and we know that we have a system that's actually going to work. And there's the final point. I can't remember what I was going to say, but the collaborative courts, this was what it was. Sort of the overall goal, we think, and it's something that I felt passionately about for a while. I remember Chris talking about it when he was in my position. We want to see if this is an opportunity to create kind of a more streamlined process to get access to these services in the community, having some sort of central entity or location where you have a substance use issue, you have a mental health issue. Let's do the assessments, let's figure out your needs, let's figure out treatment plans that work for you. And then we have, instead of this splattering of different collaborative courts, one handling addiction, one handling mental health, one handling less serious mental health, one handling people who are incompetent to stand trial, we have sort of a more uniform path, and then we can use our resources more intelligently and see if we can't get a little bit more bang out of our buck. Because right now we're having tremendous success on the micro level, but on the macro level, we're not even hitting the target yet. We're still way off center. So this is an effort to try to realign that and see if we can't figure out a better way to do it. And that's just going to require my office, the defense bar, the courts, HHSA, probation. We're going to have to all sort of come together collaboratively, ironically, in the spirit of collaborative courts to try to solve that problem together. And that's what I hope. And I'm confident that those resources and the way we handle those cases, we're not going to let these people suffer. We're not going to fail them. We're going to keep doing the right thing when we need to do it. But the way we do it might look a little bit differently than it has over the last 10 years or so. And that's the ultimate goal. So with that, I'm open to any questions you might have. I'll do my best. I'm obviously not involved in every conversation that's happening between the stakeholders in the county, so I only know what I know from people keeping me in the loop. Tony referenced the CCP meeting the other day. I still don't know if I completely understand what happened because I wasn't present for it. My understanding was that we got some permissions to use certain funding streams to help Communicare do these Prop 36 assessments, but we were requesting more money from the fund, and I know that was delayed, I think, until July to, and the reason for that being is we're actively pursuing grant opportunities in the county. And one grant opportunity, which is rather substantial, I think the Board of Supervisors was concerned that we would undercut our ability to get access to that grant funding if we had to hold these funds from the CCP first, because a lot of these grants require us to kind of start something new and don't like it when we are supplementing an existing program with it. So everyone kind of decided to put a pause on that until July to figure out what that grant situation is going to look like.
Questions?
Yeah, I have a couple of questions about the people who don't accept the treatment.
Yeah.
One of them is you said that enough people have fallen off the radar so that they're all cared for in the program right now.
Yeah.
Could you, I just want to follow up on that. What exactly do you mean by falling off the radar? They just don't want to do it anymore?
Well, they, how can I put this frankly? We will be in a situation where we're in court, usually after a substantial hearing. We call them preliminary hearings. It's when we have to show probable cause that a crime has happened, right? We have not historically had to do these with drug possessions because they've been misdemeanors for the last decade. Now they can be felonies again, so we have to go through that process.
And that's with 2 priors?
Yes, 2 prior convictions. That's what's required to make the next one a felony. And we've been trying to truncate how many of these charges we filed. So for example, if you have priors from the 90s or early 2000s and you haven't had drug history really since then, we're not filing those cases as felonies. Like, this is a tool that we're using to solve our most prolific offenders. We are big on data in my office. We have our data-driven intervention program where we have the most prolific offenders in our communities sort of on this data-driven list. And so we've been using that as a mechanism to say, yes, this person needs a lot of help. They've been suffering a lot of criminal justice sort of activity over the last couple of years. Like, this is our priority. Let's focus on this person.
So you're not taking old pot offenses?
No. And
Okay.
pot's not even eligible. It's
Okay.
It's hard drugs.
Okay.
So it's the ones that if you hear someone in your life is taking, you go, oh dear God. It's meth, heroin, PCP, crack cocaine, psychedelics, and marijuana. Not on the table. That's not what we're talking about here.
Psychedelics and marijuana are not.
That's not a qualifying conviction. If it's based on that, that's not what we're talking about. It's the kind of drug where you're going to kill yourself if you don't look out. So to answer the original question, after those hearings, judges will have discretion to release people. Sometimes they release them with probation supervision, give them a little access to resources, and our more serious drug addicts who have been experiencing the issue for many years, as you can imagine, a couple months in jail doesn't make them all of a sudden rational and functional and be able to make educated decisions about how they should handle their lives. Just because they stopped taking the drug doesn't mean the long-term effects in the brain have gone away. And so what happens the moment that person is released from custody, hits the street?
Oh, so you're saying, when you say off the radar, you mean we've
They're
actually
gone.
lost these?
They have failed to appear at their next court date. They have stopped contacting their public defender or their attorney. Probation has never heard from them. They are just gone.
Okay.
And we have had some circumstances where once they've gotten out of custody, they go, well, I'm out of custody now, so I'm good. And then they just start the cycle all over again. And then we pick up another felony charge, and then we're right back to ground zero.
The other question I wanted to ask you is, when you're actually trying to get them to take treatment, how is that conversation happening? Is it in the courtroom? Is it the public defender? Who is trying to convince them?
So there are different conversations that happen at different times. I am not allowed to have access to them without their attorney present. So the only way that I can have any interaction with these individuals is in open court. And so typically what we've been doing is whenever possible, on the record, hello, I just want to make it known that Mr. So-and-so is eligible for the mandated treatment portion of Prop 36. We would like the court to inquire if he's interested in doing that treatment.
But by the time you get there, the public defender has already had the conversation or no?
I don't know what they're doing because they pick up the case from the initial arraignment. So we first do this in the initial arraignment. Hey, he's charged with a Prop 36 felony. They're eligible for mandated treatment. That is a route we would like them to go if they so choose to do it. Any thoughts on that right now? And typically the judge will go, well, public defender, what do you think? And the public defender says, and probably rightly so, I just got appointed. I have no idea who this person is. I have not read any police reports. I do not know what the criminal history is. I don't have the ability to have a meaningful conversation with them right now. So I would like to table this later. And then somewhere between that initial arraignment and that preliminary hearing that I discussed, there may or may not be a conversation between them. I do not know. Again, if they're released from custody, the chances of them being able to reach out and contact their attorney is slim. A lot of them don't have cell phones. A lot of them don't have places to live. And so just the logistics of having an attorney get someone on the line to walk through these steps with them is difficult. So the next time that the attorney really has the ability to have a conversation with that person is at the next court date.
Unless they visit them in the jail.
Unless they visit them at the jail, exactly. So I don't know if they're having those conversations because I'm not privy to them. I'm not allowed to know about them. Those are, privileged conversations that they're not allowed to divulge to me. The only thing I know is they come to me and I ask, are they doing the treatment? And I get a, yes or no answer from them. And that's it.
Thank you.
Yeah.
Other questions?
I just wanted to say, like, as a consumer advocate, I'm pretty deeply concerned regarding termination of mental health care as a service.
Yeah.
Just because I know, like, on kind of like you said, on a macro level, it's pretty clear, like, people aren't getting served.
Yeah.
Right, but then on a micro level, I've heard, like, at least anecdotally, that mental health court has had pretty good success.
Yeah. Great
So,
success.
what I want to ask is, like you said, in part of kind of like what you were discussing, you said that services aren't going anywhere even with kind of the new system, like, initiating, right? So my question is, what would services look like moving forward for people with mental health issues or substance issues that get involved with the justice system? And I think that might be a topic for a future presentation, because I'm sure there's like a lot more about that, but I'd like to hear, hey, what do services look like moving forward for this population?
Sure. So, and I can give you kind of a brief kind of overview of how I see it working with the collaborative courts being frozen at the moment. And it's primarily utilizing the same community-based organizations and partners that we've been using kind of all along, right? When they're in custody, they have access to psychiatric care through WellPath. There also are social workers embedded in the jail, either with the probation department or with the sheriff's department, and HHSA, I believe, has employees who are in the jail as well. At any point during that process, they can be assessed through that ASAM and other evaluations for mental health needs. They can start to process the Medi-Cal and get those lined up. It would look very much like what it would look like if someone had just come off the street and reached out to the Access team and said, hey, I have a substantial problem. I need help. Help me, please. So really what would happen is we would take sort of those processes that are already built into our county system, and we would utilize them sort of in an unofficial, non-mental health court, non-addiction oriented court way when we're negotiating cases. Hey, defense attorney, I got this case. Sounds like your guy has some pretty substantial mental health issues, interfamilial violence. The rap sheet reads like somebody who has substantial mental health issues. They've been 5150 before. They've been incompetent in trial before. We have legal mechanisms in place to divert people in that situation. Let's start looking into getting them access to services locally, either through Medi-Cal or rarely, but sometimes they have access to private insurance. Like let's get the ball rolling and get those assessments started. And then once they're sort of stabilized, we can have them released into various boarding cares or some of our local Walters House and the other equivalents, and we can kind of help shepherd through the process. We can still assign them probation officers, just like they have in mental health court and addiction intervention court. They can add assistance and access to resources for them. Oftentimes, these people are already on parole because they've been released from prison from other crimes they committed earlier. So they have that resource available to them also through parole. So really, again, mental health court, AIC, the collaborative courts, what was different about them was the level of intensity that was given to that person at any given time, how much supervision they got, how many adults were monitoring them and making sure that they were following through their commitments and staying on task. But the bare bones of how those programs function, those aren't going anywhere. Those are still very much in place. That's yes, very people that need a lot of structure and a lot of care, it would not look the same. But those individuals, again, are the individuals, we call them the unicorns, like they have very serious issues, but they have a support system and the insight where they can actually do something about it. And if I have an individual like that I can work with, then I still have the tools available to me to work with them.
Okay, yeah, I appreciate your answer, but I think it might be helpful to get kind of a more detailed like presentation on this in the future about kind of like how these systems would work without mental health court.
Yeah, sure. That's something we'd have to put some time and energy into, but yeah, absolutely.
Can you do that? I just have couple of questions. Mental health court, is it paused or is it shut down?
It's so the way it's working right now and the way we have designed the programs is our office has never been able to say, no, you can't refer someone to this program, right? So those referrals are still coming in. They've slowed down since the pause, but they're still coming in. And HHSA staff and the probation department who take charge in assessing the individuals, whether or not be accepted into the program, are still doing those assessments. The part that is frozen is in order for someone to be accepted into either of those programs, every single stakeholder, except the court doesn't vote, but the defense attorney, the DA, HHSA, and probation all have to unanimously agree that this person should come into the program. If any one of us object to it, they don't come into the program. So that's the part that is frozen because we're not agreeing to bring new people into the program at this point. So that's where the pause has happened.
So I'd heard that it was going to pause until January 1st of 26. If Proposition 36 gets up and running and there's funding, could it resume the referrals and people being admitted into mental health court? Could it resume earlier than January of 2026?
Yeah, I mean, we're making our own deadline, right? We're drawing kind of imaginary lines in the sand. If we have a process that's in place and everything is working smoothly, and we understand that it's not going to impact the resources in a negative way, then all we have to do is say, yeah, we're open for business and we'll start accepting people again. It could literally happen like that.
Chris?
Your vision going forward, is this court appearances where mental health court would be separate from the other two?
Yeah, so right now
The reason I asked that is best practices is not to mix the seriously mentally ill in court with other populations.
Right. Yeah, so right now we have the court agreeing to do a Prop 36 calendar, which would handle the Prop 36 drug cases. Obviously, there's overlap between mental illness and substance use a lot of the time, and the co-occurring disorders is a real issue that you have to somehow figure out how to untie. But those would be handled in a separate department. My hope, my vision, what I would like to see is to have all these sort of courts consolidated just into two paths, one focusing on sort of a substance use Prop 36 path, and one focusing on a mental health, serious mental illness kind of path. And for the individuals that have a little bit of both worlds going on, we'll have to, like we've done in mental health court at AIC, prioritize which court would be a better fit for them.
For individuals going to mental health court, they have to be a full service partner eligible. Who is making that determination? Because historically it's been the county, not a service provider or contract service provider.
It's still the county, my understanding. It's still, in the meetings I've been to, and Chris Chris's job was really complicated. I didn't appreciate how complicated it was until I started doing it. But based on my understanding, there are only a certain amount of full service partnership slots available in the county, and it is HHSA that makes that determination on it.
Because the mental health court treatment side has been funded through MHSA with 30 FSP slots dedicated to that program. And those services are provided by county employees. I will say that over the 10 years that we had that program, and ever since we contracted out the FSP services, the quality of the services by the county forensic team has been superior to the services that are contracted out. And if we have vacancies for Yolo County residents that need those services, I would highly encourage your office to find a way to try and start up that mental health court so that the community members who need that high level of services will get them. We heard public comment earlier about how the level of concern amongst community members for individuals that won't be getting those level of services. Right. So I think it's vitally important to try and open that valve, so to speak, for that program, because those services, there's staff to provide them. That also involves housing. For those people who are new, if you're a full service partner, you're eligible to get housing. One of the big challenges with the seriously mentally ill is that they're unhoused. And if they're unhoused, which I suspect a lot of that 11 were that fell off the radar, it's hard to keep track of them. It's hard to make sure they get their medication. It's hard to get to their appointments. And so when we have a resource for housing and that level of services, it's important to try and maximize how we utilize it. So that's just kind of my comments, and I'm relieved that they're not being mixed into the same court appearances, because I think that's dangerous.
Yeah.
The seriously mentally ill, quite often, if they've been homeless, can be taken advantage of by other people who are homeless that may not have their level of illness. And so that's one of the reasons to keep them separate.
Every homicide we've seen in West Sacramento over the last, I think, year and a half, 2 years has been homeless on homeless homicide. With the exception of a couple of DV incidents and other things, but.
Any other questions?
That's heartbreaking.
Any public comment?
I don't know if it's appropriate for me to comment here, but just to clarify, at the Community Corrections Partnership meeting the other day, there was a proposal with regards to mental health diversion court and allowing, or kind of like creating some allowances with expanding the scope of that program to allow for that program to serve Prop 36 defendants, right? But in addition to the agreed upon, the agreement that was made at that meeting, it was to continue the mental health diversion court in its current state, right, until July, right? Because there was some concerns about some individuals who are currently in mental health diversion court, and ending that would make it impossible for them to complete that course. So I just want to make sure that people understand that that is still continuing until the meeting in July, where there's some other decisions that can be made about that, right?
Right.
And that we're continuing to on the Health and Human Services and Behavioral Health. We're continuing to look for ways to partner with the district attorney's office and probation and the public defender, right, around how to meet the needs. And there was a pretty robust conversation at that meeting around, and I forget the specific code sections, but it's 11395, which is Prop 36 stuff.
Yeah.
I think it's 1011.36, right? And just really some concerns about there's some significant overlap between those two populations, but then there's some individuals that really could only be served by 1001.36, and making sure that we keep some structures in place to be able to serve those individuals as well.
Yeah, and the only reason that overlap exists is because 1001.36 requires a DSM-5 diagnosis, and substance use disorder is a DSM-5 diagnosis. So that's the access point for that population.
Yeah, so just to provide a bit of an update, mental health diversion, we're continuing to work with those clients, and And we're looking for ways to incorporate opportunities to serve Prop 36 individuals as well.
All right, we're gonna go to the ad hoc committee. I'm gonna table the site visits. We can do the nomination committee. The committee has a slate, and so Nikki's going to tell you what the slate is, and then we're gonna vote next month on it, so.
Right. So the nominating committee, having duly beat the bushes, has come up with a slate. And the nominee for chair for the next year is Meg Blankenship. The nominee for vice chair is Sue Jones. And the nominee for secretary is Kimberly.
All right. Oh, Christy, you wanted to make a public comment? Actually, I'll get to public comment a little later, if you can just hold off, we're almost done. Okay, so site visits, we're gonna table. If I could do this really quickly, and this is what Kimberly brought up, I wanna establish an ad hoc committee for the annual report, which is due, when was it due again? June. And so, I know Kimberly would like to be on that committee. Sue would like to be on that committee. I'd like to be on that committee. Anyone else? Would anyone else? And by the way, I see Meg, I'm sorry. And if anyone else decides they want to be on it or wants more information about what it is, we can talk about it. I'm not limiting it to that, but maybe the four of us can start, thinking about it, and maybe there's some good samples of reports on the Cal BHPC website, if you can look at them. So we have 4 people so far for that ad hoc committee. Meg, Jonathan, Kimberly, and Sue.
Okay, I just wanted to add to the nominating committee report. We can open nominations from the floor. This is a meeting where a lot of people on the board are not present. And so I'd like to have a slight aberrations of the Robert's Rules of Order procedure for this. I would like to publish the nomination in the nominating slate currently in the minutes, and ask if there's someone else who would like to run from the floor, ask that they contact Maria or myself before the next meeting, so that we can have a chance to talk with them and either include them or not on the slate that we get to vote on. Will that work?
Yep.
Okay.
Okay, thank you, Nikki, and thank you, Maria. And so I'm gonna table the long-range planning, item 12, because we're so late. I'm so sorry, we're half an hour late. I'll go back to public comments, and I know Christy had a comment.
So my public comment, I'm trying not to have questions. Basically, I'm just concerned with how this is gonna play out for either the people in the current FSP spots, because that's MHSA funding, and I know it's usually a 2-year cycle. I hope they're full. I hope that the 30 stay full. I know that HHSA can either lower that count. But my biggest concern is those people sitting in the jail that won't have the opportunity for diversion. And I believe you, Preston, when you say that there are opportunities, but keep in mind that not everyone that enters a jail that has a serious mental illness has a diagnosis or has a prior record. It's been my family's experience that, that crisis was his access point. And unfortunately, we couldn't get to a clinician or a hospital. We got to a Sally Port. So, this is a really good time for this board to examine the WellPath scope of work contract and look at how people in the jail who are suffering from a serious mental illness can get access to treatment. And I have faith in HSSA. I'm just worried about the gaps now. I'm worried about things like DEJ. I'm worried about, just how anyone in the Monroe Detention Center today can get some sort of treatment and help if there isn't that leverage, if there isn't that social worker if there isn't that wraparound service and those touches. So, you know, I understand what's going on with the restrictions and the need and the mandates. I'm just looking at the importance of going upstream and having an alternative to the jail to access treatment in Yolo County. Thanks.
Thanks, and I share your concerns, Christy. I appreciate that. I'm sure others do too. Any other comments? All right, again, apologies for going long. Thank you, Tony and Sam, for the presentation.
I also just want to thank everybody for meeting out of their normal schedule.
Yeah. All right, and we are adjourned.
Thank you.